Here is the game plan for our explainer today. We're covering 1. The parathyroid gland basics, 2. Primary hyperparathyroidism breakdown, 3. Surgical management and protocols, 4. Secondary and tertiary disease, 5. Cancer and rare mimickers, and finally, 6. Understanding hypoparathyroidism. Let's get right into it.
Section 1. The parathyroid gland basics.
So there's this fantastic quote from a surgery professor that just perfectly hits the nail on the head when it comes to identifying these things in the OR. First, you find a hummingbird, wait for it to get jaundice, and then stick out its tongue. I mean, how incredibly vivid is that? These glands are insanely tiny, slightly yellowish, and they actually change to a dusky color when stimulated. Because they're so small and delicate, they are so easy to confuse with a random lymph node. Surgeons literally have to hunt for a specific little sentinel pad of fat just to track them down without snipping the wrong structure.
Let's talk about where they actually come from. The superior glands pop out of the fourth pharyngeal pouch, while the inferior ones drop down from the third arch. Now notice how does inferior glands share their embryology with the thymus? This is a massive clinical pearl right here. Because of this shared origin, those inferior glands can wander all over the place. Their location is totally unpredictable. That's exactly why a surgeon might actually take out the thymus just to increase their yield when hunting for rogue, overactive, inferior parathyroid tissue. Oh, and here's a fun fact for you. The blood supply comes from the inferior thyroid artery, and get this, about 5% of the population is just walking around with 5 parathyroid glands instead of the usual 4. Crazy, right? Moving right along to Section 2, Primary Hyperparathyroidism Breakdown. So, what actually happens when these little glands go totally rogue and pump out way too much parathyroid hormone, or PTH? Well, it literally sucks the calcium right out of your bones and floods your bloodstream with it. In med school, we use this classic, unforgettable mnemonic for the systemic havoc it causes: bones, stones, abdominal groans, and psychiatric overtones. The excessively high calcium eats away at the bone, which shows up on x-rays as scalloping on the radial side of your fingers or a salt and pepper-looking skull. It creates recurrent, painful kidney stones, which, by the way, is the most common way this actually presents in a patient. It causes massive colicky stomach pain, sometimes even pancreatitis, and it actually depresses your central nervous system, leading to confusion and psychiatric issues. It's the whole shebang. Now, if we're going to fix this, we have to know the root cause. Are we dealing with a single enlarged rogue gland? That's called an adenoma, and it's by far the most common culprit. Or are we looking at hyperplasia, where all 4 glands are swollen and firing off at once? We actually see this a lot in inherited conditions like MEN1 syndrome. Figuring this out is absolutely crucial because it completely dictates our surgical approach. But how on earth do we figure that out before we actually cut into the neck? Surgeons rely on something called a technetium-99m sestamibi scan. It sounds super complex, but it's basically a brilliantly clever nuclear medicine test that hunts down mitochondria. Because overactive parathyroid tissue is just absolutely stuffed with mitochondria, it lights up beautifully on the scan. But here is an insider pro tip you've got to watch out for. Warthin's tumors, which are found in the salivary glands, are also totally packed with mitochondria. So they can light up right alongside the parathyroid and give a false positive, completely tricking an unwary doctor. You've definitely got to keep that in mind. Okay, before we even think about making any surgical cuts, we have to stabilize those dangerously high calcium levels. And it has to happen in a very specific, strict sequence. You can't just throw drugs at the problem right away. First, in the immediate term, you've got to flush their system with aggressive IV fluids to get them hydrated. Then, in the short term, after a few hours, you step up to IV diuretics, like furosemide, which forces the body to excrete that excess calcium. Finally, over the next few days, once you are absolutely sure their kidney function has normalized, you bring in the IV bisphosphonates, like zoledronic acid. That's the heavy hitter that locks the calcium right back into the bones where it belongs. All right. Section 3. Surgical management and protocols. Now, the patient is medically managed and stabilized, so let's get into the definitive treatment. Imagine a surgeon taking out a gland, stitching the patient up, sending him home, and a month later, they come back with the exact same symptoms because the surgeon accidentally removed a lymph node instead of the adenoma. Total nightmare, right? To absolutely prevent this, we use the Miami protocol. Here's the trick. Parathyroid hormone has an insanely short half-life of just 7 minutes. So the surgeon draws blood right before taking the suspected gland out, waits about 15 to 20 minutes, and draws blood again. If that PTH value drops by more than 50%, boom, that is definitive real-time proof they got the right gland before they even closed the neck. But wait, what if the patient has hyperplasia and all 4 glands are diseased? We obviously have to remove the bad tissue, but we can't leave a human being with 0 parathyroid function. So what's the workaround? It is so cool. We take out all 4 glands, take a tiny piece of one, chop it up, and literally transplant it directly into the brachioradialis muscle of their non-dominant arm. Why the arm? Well, if the disease ever recurs, the surgeon can just do a quick, minor procedure on the arm under local anesthesia to remove it. It completely avoids the incredibly dangerous nightmare of dissecting through heavily fibrous scar tissue in the neck a second time. And the care doesn't stop when the surgery ends. Right after a successful operation, you have to be on extremely high alert for something called hungry bone syndrome. Think about it. For months, maybe years, these bones have been battered by high PTH and aggressively stripped of their calcium. The absolute second you remove that hyperactive gland and the PTH levels plummet, those bones act like a dry sponge. They get incredibly hungry and they suck up calcium from the blood so aggressively that the patient can rapidly crash into severe hypocalcemia. This is exactly why constant post-op monitoring is completely non-negotiable. Moving on to Section 4, secondary and tertiary disease. So what happens when the parathyroids aren't actually the root of the problem at all? This table right here is your ultimate high-yield cheat sheet for figuring that out. Look at secondary hyperparathyroidism. The actual villain here is usually chronic renal failure. The failing kidneys can't activate vitamin D, which means your gut just stops absorbing calcium. Your body senses this desperately low calcium level and forces the parathyroid glands into overdrive, making all 4 of them swell up. So you end up with low calcium but high PTH. Now, if that secondary state goes unmanaged for years, the glands mutate. They go totally rogue, stop listening to the body entirely, and become autonomous. That is tertiary disease. Suddenly, both PTH and calcium are skyrocketing, and at that point, surgery is your only fix. Why does all this matter? Well, the crucial point here is understanding the terrifying consequence of ignoring secondary or tertiary disease, a complication known as calciphylaxis, or hypercalcemic uremic arteriopathy. This happens when all that excess calcium and phosphate form crystals that deposit directly into the blood vessels and subcutaneous tissues of your skin. It literally chokes off the blood flow, causing agonizingly painful skin nodules that rapidly turn into gangrene. When this happens, it is an absolute emergency. It requires an urgent parathyroidectomy just to try and reverse the tissue death. Okay, we are nearing the finish line. Section 5, Cancer and Rare Mimickers. Let's look at the rare outliers that mimic or escalate these calcium crises. We have to carefully distinguish between true parathyroid cancer and its imposter. Actual parathyroid cancer is incredibly rare. It's driven by genetic mutations like the inactivation of the HRPT2 or parafibromin gene, and it requires a super aggressive R0 surgical resection, meaning the surgeon has to take it out with completely clear margins. On the flip side, we have pseudo-hyperparathyroidism. This is a paraneoplastic syndrome. Basically, a tumor somewhere else in the body, usually a squamous cell carcinoma of the lung, is tricking your system by releasing a compound called PTH-related peptide. It acts exactly like PTH, causing massive hypercalcemia. But your actual parathyroid glands? They're completely innocent bystanders. Finally, Section 6, Understanding Hypoparathyroidism. Let's briefly look at the exact opposite scenario to complete our blueprint: what happens when we lack parathyroid function entirely. While the most common reason is accidental removal during neck surgery, on the genetic side, we often see this in DiGeorge syndrome, which is caused by a 22q11 deletion. To remember the severe clinical features of this congenital condition, we use the incredibly handy Catch-22 mnemonic: cardiac defects, abnormal facies, thymic hypoplasia, cleft lip and palate, and of course, hypocalcemia due to those missing parathyroid glands.